All right, thank you everyone for joining us. My name is Faris Samra, and I am the president of the SAMS Tri-State Chapter. Today I'll be moderating our talk on implementing COVID-19 testing and the lessons learned in our chapter. We have two great speakers for us today. We have Dr. Ammar Bazarbashi. Dr. Bazarbashi went to medical school in Damascus and then completed a wound healing and dermatology clinical research fellowship at Boston University. He did his internal medicine training at Michigan State University and is board certified in internal medicine. And he is now in private practice at the Medical Arts Center in Middletown, New Jersey, with his own moderate complexity lab. He has truly been at the forefront of COVID testing since the beginning of the pandemic and is in regular contact with both state and federal agencies. We also have with us Dr. Renda Elkana. Dr. Elkana did her medical school in Damascus University as well, and she did a residency in anatomical and clinical pathology at Monmouth Medical Center. She also completed a fellowship in hematopathology at Robert Wood Johnson University Hospital and is board certified in anatomical and clinical pathology as well as hematopathology. Dr. Elkana currently works as a general pathologist at New Jersey Urology Diagnostic Lab. So the agenda for today is, this introduction, and then we'll have talks from both Dr. Elkana and Dr. Bazarbashi. Dr. Elkana will be talking about the testing methods of COVID-19 and some of the clinical pathology involved. And then Dr. Bazarbashi is going to be speaking about implementing COVID-19 testing in private practice and some of the challenges and lessons that he's learned. We have planned for a good amount of time for questions at the end. Of note, all of those who are attending will be muted throughout the webinar. And so if you have questions, please submit them through the question and answer function of Zoom or through the chat. And I will be happy to ask those questions on your behalf at the end of the talk. The only other thing is that, the information that we present today does not represent SAMS. It has been, thoroughly vetted and has been collected from reputable federal and state sources, and is as up to date as possible given the current knowledge. As all of you know, this has been rapidly evolving, however, and so what we say today, unfortunately, may not be accurate even a week from now. So, please keep in mind the timeliness of this information. So, without further ado, Dr. Elkana, please go ahead.
Hello, everyone. I would like to thank first SAMS for giving me the opportunity to participate in this informative presentation. This image, it shows just the basic structure of COVID-19, which is mainly, as we could see, it looks like a ball with the spikes protruding from the surface. We have the surface of it, and also inside there is membrane and the nucleic acid. So there are basically 4 proteins or structures of this virus. And what's expected that each protein of this virus can really induce different antibody in the host cells. But what's expected that the spike protein is usually the primary one that interact with the host cells, and probably if the vaccine will be addressed is usually toward those spikes. There are 2 types of immunity against pathogens in general. It could be cellular immunity or cellular reaction, or antibody reaction or antibody forming immunity, which is usually products from the B lymphocytes in the lymphoid system. And those antibodies that are against any pathogens can be different, and they are not created equals. So some of them are made, but they are not effective in giving immunity, and some of them are very effective and long. It depends on the quality and the quantity of those antibodies produced to give you the immunity. And that's why there is so many debates about those antibodies, whether they are effective or not, because they are not sure how much the immunity can be introduced by those antibodies until further study is done. The COVID-19 testing, there are three ones. The first one, which is the viral RNA done by procedure PCR, polymerase chain reaction, is to diagnose the infection. And the sample usually is nasal swab, upper respiratory, or from the lung. The other method is to examine the viral antigen, which could be the surface or could be the spikes. And it's also to diagnose the infection and the specimen usually from the nasal swab or a nasopharyngeal source. The antiviral antibody, it's a blood test and usually to diagnose prior exposure and possible immunity. And as I said, it's blood, serum, or plasma that is used to do this testing. The method are, they are different methods of doing the testing, but the basic ones that usually the most common ones is ELISA and IFA or immunofluorescence assay, and those are antibody testing. And there's another testing done usually in more research-oriented or reference labs called neutralization, which usually measures the effectiveness of the patient antibody and how much of the patient antibody can inhibit viral growth in the lab. The PCR testing is it's usually qualitative detection of nucleic acid of COVID-19. And as I mentioned before, samples can be nasal or nasopharyngeal, oropharyngeal, aspirate, and wash or swabs. It can be used as sputum. Usually this is in hospital setting or lower respiratory tract aspirate or bronchoalveolar lavage. As I said, the last two of them are usually in the hospital setting. The top two is usually in as an outpatient in the hospital or as office or the lab testing done as an outpatient. The turnaround time usually is 7 to 8 hours from the time the specimen is received in the lab. There is another testing that is usually called rapid diagnostic tests, which usually it's a point of care testing. It's, as it says, rapid, it's give you some information on the status of the patient. It's usually the antibody or can be the antigen. The turnaround time is usually 10 to 30 minutes, and it's not available now yet to use in office setting because all those testing are prioritized to go to hospital-based or surgery centers or whoever needed it in a prior or more, it has more priority. But maybe later in the future when there's more of those available and kits are available, they can be done in office setting. The ELISA testing, which is called enzyme-linked immunosorbent assay, is lab test only. It cannot be done in the office. And that's very important for if anybody of the vendors that are trying to sell any kits, that certain tests cannot be done or are not allowed to do, even if you buy the test from them, but you cannot do it as a office-based testing. And those tests are turnaround time between 2 to 5 hours. And the neutralization assay, as I mentioned before, it usually detect and exhibit how much the antibody can inhibit the growth in viral growth in ex vivo setting. Usually those are for vaccine and research-oriented testing. And this is one of the methods that when they do the effectiveness of the antibodies that are produced after the vaccine is introduced.
Okay, thank you so much, Dr. Elkana. We appreciate that foundation, and I think it's going to really lead as a great springboard for Dr. Bazarbashi's talk, understanding the story of his struggle and success. Dr. Bazarbashi.
Thanks, everybody, and thanks for attending this lecture. When Dr. Faris actually asked me to give this talk, I felt a lot of relief because that hopefully actually will prevent a lot of phone calls that I've been receiving to discuss what what could be done for COVID. We happen to be at the frontliner. We started testing in our office early or mid-March, and that was for a lot of reasons. The way I'm going to start this, I just want to make it very practical to our to clinicians, which I'm one of them. I just want to actually identify and define what CLIA means. CLIA have 3 categories. CLIA waived, that's what most doctors do. That's when you do the urine test, you do the strep test, pregnancy test. Usually you have a CLIA waive certificate. You can upgrade it and you can become a moderate complexity. Moderate complexity, you can do more tests, more complicated tests. If that one, actually, you will be inspected by CLIA and by the state. But as a doctor, you could be the director of the lab. When you go to high complexity labs, those are the labs in the hospital, the reference labs, they could be actually small private labs. I think in New Jersey we have 30, 40, 50 high complexity labs. But those usually, they have a certain criteria and they do more advanced and complex tests. Point of care, when we say point of care, I believe most of us know what that means. Point of care, when you do the test at the bedside, the patient bedside. So you can do the urine test, you can do the strep test. That something can be done easily and can give you immediate results. This is very important to remember. Emergency use authorization or emergency utility authorization. When we are in pandemic situation, when we have an emergency situation, the FDA steps back and say, we're not gonna go through the official process of approving any test. Every test in America now has not gotten approved by FDA. It took me a month to not say FDA approved, to say got the EUA. So none of the tests that you see has been approved by the FDA. And when the pandemic is over, we have to go back and we have to go through the official way to get approved. So the EUA is being in a pandemic situation, emergency situation, it fast track authorization to use the test during this time, but yet when this is over, you still have to go through the normal official way. And this is very important to remember. So what type of tests we have? Start with PCR, start in February, and that was actually when the CDC was doing it. Just recently, we started having the antigen swabs that came out, I guess, a few weeks ago. And then we have serology tests. And I'm gonna focus on that at the end, because that actually will be important for every clinician to protect him and herself legally from doing something they're not allowed to. Because the FDA, and I have spoken to them several times, and they are very concerned about a lot of this that has been manufactured outside the country and been sold in the country, and that has not been authorized, not approved, authorized by them. Next. There are 90 tests that has gotten the EUA. Again, it's not FDA approved, got the EUA for the emergency situation. 35 of those 90 are developed by the labs. When you are a high complexity lab, you can make your own test, but you can use it only in your lab. So if you go, I'm gonna show you on the FDA website, so everyone will be able actually to see that. When you go in there, you will see that some of them, like Mount Sinai, they developed their own, and they can use it only in their lab. Next. PCR. PCR is not the gold standard. We do not have a gold standard yet. It's the best available test. It's very, very specific, but it's not that sensitive. I have a patient and she was pregnant, fortunately, but unfortunately, and she got 3 swabs and the 3 of them came back negative and she was positive. And we confirmed that in a different way. So if the test came back positive, it's almost 100% positive. But if it comes back negative, that does not mean it's 100% accurate. Molecular test, there are 72 of it has gotten the EUA. 57% of them for high complexity labs, reference labs. We're not going to discuss that. One of them has the home collection kit. With that kit, the patient can do their swab at their convenience at home, and they can put it in the mail and they can send it to high complexity lab. This is not approved in New Jersey, by the way. That was like 10 or 14 days ago. You cannot do the home collection in New Jersey. That might be changing. 10 of them are moderate complexity. Moderate complexity labs could be a doctor's lab. I have a moderate complexity lab in my office. And 4 of them are a CLIA waive. So that means every doctor who had the CLIA waive certificate can perform them in their office. 13 manufacturers are doing the high complexity lab, and there's 140 who do not have the EUA yet. And this is why this is important, because a lot of companies are trying to jump in, which is great because that will make it easier for us to test. But yet, those tests we have to understand the language. If the test has not gotten the EUA, that means it can be only used in high complexity labs. And if it's developed in the high complexity labs, it's only for that own lab. This is actually what might be very important and relevant to most clinicians. CLIA waive, because most of the doctors have the CLIA waive. You do not need any validation. You don't need to contact the Department of Health. And the famous one is Abbott Id. This is the one that's mentioned that's in the White House. And this one actually, unfortunately, is very, very hard, not impossible to get, but it's legal to have. If you can get it, you can perform the test, but it's so hard, if not impossible to get. The allocation is only for acute care facilities and government agency. Mesa Biotech is another one. It's so hard to get it now. Then we have the CEPID. The CEPID, you can get the machine tomorrow. So easy to get the machine, but you cannot get the reagents. And that might take a few months. It's also CLIA waived. So hopefully in the next few months, that will have, and they will manufacture more machines and will be available to every doctor to do the test in his office. And just recently we got the Sophia. The Sophia is not PCR, it's an antigen. That might be easier to get, and I know they are in the process of manufacturing a lot of those machines. Even now, it's so hard, and you have to write a novel. Actually, I myself, to get, and I'm moderate complexity, I had to write like 2 pages of how important for me to do the test, for them to approve me. How do we get the samples? Like Dr. Alkana said, you can do the nasal swab, nasopharyngeal, you can do oral swab, saliva, sputum and tracheal bronchial wash usually is done in the hospital. And that's how we knew about that patient who was 3 times was negative. When they did the tracheal bronchial wash, she was positive. I don't know why they did it, because I wouldn't do it, especially at the early stages. You don't want to do bronchoscopy on someone who has, because you're exposing yourself. In April 13th, the saliva one was developed by Rutgers, and the accuracy was comparable to the swabs. And that helps to preserve the PPE and was more comfortable for the patient to do, so they don't have to have the swab. Now that one, the home collection, it got the EUA. To do collection in the house, you have to get the emergency utility authorization. When you do the swab, please make sure that you have N95 or higher. You have to remember, when that happens, first protect yourself. It's like, you see someone drowning, you want to make sure if you're gonna catch him, you're not gonna drown with him. So you have to protect yourself. You're needed. And we've heard about a lot of doctors and a lot of healthcare providers, unfortunately, who died because of that, and because lack of PPEs at one point. Nonetheless, make sure that you have N95, you have eye protection, gloves, and gown. And we're not going to go in details, but if you have enough, make sure you change them in between patients. They could be reused in a certain situations, but you have to know how to reuse them. Swabs, what type of swabs? The whole story started actually, and I'm telling you actually a story now that when we started in early March, it has to be nasopharyngeal swab, it has to be synthetic fiber, it has to go in specific transport media. And I happen to have some because I do the other swab before COVID, the normal one. But after a while, you know, I mean, I'm contacting LabCorp, they send me 20 kits and I sent them 200 swabs. So I went and I bought the swabbing kits and the transport media, but then I could not find them anymore. So we were spending times and hours to try to buy them and do the, not perform the test, to do the swab and the test and send it to LabCorp. And at one point we could not find any. The way you do it, you just insert the swab in the nose till you get to the palate. When you feel any resistance, you should not keep going. You stop, you rub it, and then you take it out, you leave it for a few seconds, and then you take it out and you put it in the other nostril. It's not that comfortable. Some patients really do not like it, and they stop, some of them start vomit, but this is how it's performed. If you look at it, it's very slim though, and it can go, but it's not comfortable for the patients. Oropharyngeal swab, I'm not a big fan of it. The sensitivity for this is around 35%. You cannot use any wooden shaft with it. You need to use synthetic fibers. The reason with the wooden shaft, the wood actually can affect the virus itself. Now, after we started a month or a month and a half after, the FDA agreed to let the cotton swab. Cotton swab are very widely available, very cheap, and they said you can put it in a normal saline. That was a huge relief, huge relief. As I said, it was an agony to go and find those swabs and the media transport. It's as if like we contacted companies in Italy, we contacted companies all over the world, you know, nobody has it, no one. And then all of a sudden, actually, we now can use the cotton swab with that wood shaft, and you can put it in normal saline, and that will be fine. And actually, since that has been not approved, agreed upon, we've been getting a lot of swabbing kits from LabCorp and other labs because now it's easy and simple. The way you do it, the oropharyngeal, just put it in the throat and you rub it around. You have to avoid the tongue and the teeth. It got better actually. The cotton swab, you can use it for the mid-turbinate, meaning you just put it in 1 inch, 2.4 centimeter. Try actually to rub it against the wall and try to get as much secretions as you could, and you take it out and you put it in the other nostril. You don't have to push it all the way, just 1 inch. Got even better. They said anterior turbinate was accepted, which means ½ an inch. So you barely put actually the cotton portion of the swab and just have to leave it there for, I usually leave it 20 seconds, not 15. Try to rub it with the wall, and then that was very much more comfortable for the patients and for us, because you just put it in the normal saline and we send it out. I mean, again, as I said, when we started, because there was not a lot of transport media available, we went actually and we were pouring the transport media from one tube to another to create more swabbing kits, because they told us you don't need 3 ml, 1.5 would be enough. That's how much we went through. The antigen swab, that's probably gonna solve a lot of problems, hopefully soon. It's a rapid point of care test. It's like doing the flu test. It's an antigen, not PCR. The PCR check, like Dr. Akana said, check for the RNA or DNA, in this case RNA. So it checked for the genetic one. The antigen only checked for an antigen in the virus. The insurance will like it more because this is cheaper, of course. It's very, very cheap. Actually, I was on a phone call 2 weeks ago with someone who's in California, Silicon Valley. He is actually making one of those antigen tests, and he said, I can make it for 10 cents. Rapid results, very specific, but not very sensitive. Meaning if the test comes back negative, you still have to do the PCR. If the test is positive, you can rely on for treatment and diagnosis. Serology testing. And that's what I want to make sure that everybody actually understand the situation in here, just to protect everyone. We use the serology test to see if the patient have the antibodies. Use of tests without EUA. Any test, when you go on the website and you're going to see the link, does not have an EUA, the emergency utility authorization, only for high complexity lab. It cannot be used by moderate or clear wave. Meaning if someone calls you, like I see Ashley, or send you a picture of a kit that looks very simple and easy to be done, as simple as doing pregnancy test, if that test did not get the EUA, can only and only be done in high complexity lab, no matter how simple it is. And every time I speak to the FDA, they say, that's how it's gonna be and how it's gonna stay in the EUA. And the state always say, please, let us know if anyone is selling them without the EUA. Now in the near future, hopefully that will change, but this is the situation now. When you do not have any EUA, there's no validation. And the one that we have actually, they go, if you wait more than 20 days, the sensitivity and specificity probably actually approach 100% more than 20 days. So the longer you wait after the infection, the more chances the person has developed the antibodies. Of course, we test for IgM, IgG, and IgA. Forget about IgA now because that's, I mean, again, take probably have a lecture by itself. IgM, we do it. It's not our major concern because it's very variable. Sometimes you don't even see it. It's a short memory immunity. We rely on the IgG, which is the most important one. And that what we think that actually give the immunity, and that will stay for a long time. It starts after 10 to 14 days. Give it at least 21 days. It could be before. Do not judge it before. Repeat the test. How long does it stay? We do not know yet, and that's to be told. And the CDC now is looking at that and see how long the IgG will stay in a human body. So why do we perform those tests? We want to see how many people has gotten the infection, because there's a lot of people, has gotten the infection and they did not know. Funny enough, actually, if any of my staff there actually would know that I had a 92-year-old, she came and she says, can you do the blood test? We did that and she came back positive, never had any symptoms. We want to see if people are having immunity, if people get re-exposed, if we can use their blood to treat critically ill patients. My perfect scenario, when you have a positive PCR, draw blood right away. Because if you do it right away, theoretically, you're probably going to be negative. Then if you do it in a week after, theoretically, you're going to have IgM. And a week or two after, you'll have IgM, IgG, and then IgG. This is the perfect scenario. Not everything in medicine is perfect, of course. But if you do it that way, you can probably be certain that the developing of the immunity is for COVID. It's not because of other coronavirus, because it was negative, then after the IgM, then IgM, IgG, and then IgG. So you had a screenshot of every phase of the immune reaction. Of those serologic tests, there are 5 high complexity, 13 moderate complexity. That's what we're going to be, the five of them are rapid tests. That's what I want you to remember. There are 5 rapid tests up to May 6th, unless actually today or yesterday something has been approved. I haven't looked actually. If you look at their sensitivity and specificity, it's actually quite high. Now the selects, it's almost impossible to get. You cannot get it. That was the first one that got the EUA. ChemBio is the only one that you could do with finger stick. Problem with it, you have to buy 2,500 and they charging around $25, something like that. So you have to pay 65,000. This is the minimum amount you have to buy from ChemBio. Again, this is it's not clear wave. It's moderate complexity, and you have to wait 3 weeks. AutoBio is the third one that got approved. Cheaper, actually, it's like $5, $10. And this is the one we order, and you have to wait for a long time. Right Sign, it just got the EUA 2 weeks ago. And Helgene is the one that McKesson is selling now. I just got the email today, actually. And they have actually compatible sensitivity and specificity. Now, those tested, all of them, none of them is a clear wave. There is no rapid test. There is no kit is a clear wave. More so, none of them could be done at home. So if anyone tried to sell you any kit, all what you need to do to go on the website and check if that, you can have the next one. Go to the link, and you can see actually it's very easy and simple. Like if you look, for instance, Cepheid in here, it says HMW, H high complexity, M moderate, and W wave. Some of them are only H, which means high complexity. HM, high complexity and moderate complexity. This is BioFire, actually the one in the middle. This is what we have in our office for the PCR. This is actually, those information every doctor has to know, because the companies can sell you those tests, but you are supposed to know if you are allowed to perform it in your office or not. It's not their responsibility. So if the test is high complexity and you are performing in your office, you are breaking the CLIA guidelines. There are serology tests without EUA. The FDA, I spoke to them probably the last time was, no, before the last time, 4 weeks ago, and they had 42 applications. Now they have 192. A lot of companies are trying to get into that, especially with the kids, because they are simple, not simple, they are, yeah, simple and easy to make them, but they have to be done right. And they are easy to use. And that's why the FDA is very concerned about it, because a lot of them, they're not validated, and the results are very poor. So they don't want to approve something that will give you poor results. I shouldn't say approve. They don't want to give the EUA for something that give you poor results. Now, after the FDA give the EUA, they will categorize it as a clear, waved, or moderate, or high. Most of those tests are rapid diagnostic tests, and they are working a lot of companies, and the FDA are trying their best to give them the EUA, but that's going to take time. There are 22 laboratories, they develop their own, and they can use it only in their labs, so they cannot sell it to anyone. Home testing. Home collection kits require EUA, meaning to collect the sample, just to collect it at home, not in your office. In your office, you don't need, a doctor can collect the sample. But if the patient want to collect it at home, that test has to obtain the EUA. They cannot collect the sample with that for any test unless it's gotten the EUA. The EUA does not apply for home processing. Remember, all this actually regulation, those are emergency regulation. Those are not the normal regulation. So why this kit is not allowed? Because they said this is emergency situation, and we expect a lot of scam out of this that are easy to make. They're not big analyzer. Anyone can make them. So that's why they don't want anyone to perform the test at home. They allowed it to collect the sample to make it easier and to do more testing. But there's no test under EUA to be done at home. So if your patient shows you that they perform the test at home, right away, automatically, you're gonna say this is illegal. And again, you do the collection and you send it to high complexity lab at home, when you do it at home. So let's summarize the important points. Point of care PCR tests are CLIA waived. So anytime they tell you this PCR test is a point of care, automatically means it's a CLIA waived. We gave 3 samples. The Cepheid is a CLIA waived, the machine, the MESA, and the Abbott Id. And the Sophia is also an antigen, and it's also CLIA waived. If you can get that, that would be great, and that will help you and help your patients. However, the rapid serology tests are not point of care and are not CLIA waived, and you cannot do them in your office. More so, you cannot do them at your house. So the pharmacy should not be selling those. And you should not be buying them from anyone. Again, remember, any test that does not have an EUA, and you can find that on the website of the FDA, automatically by default become only for high complexity labs and cannot be done at a doctor's office or at a moderate complexity lab either. All rapid tests that's available now are moderate complexity, and the FDA has no intention to change it. And I think the reason is because there's a lot of manufacturers of this, and they want to control it. They don't want it to go like too wide. And it's already gone actually that wide. People are selling them in pharmacies. People are getting it from over the internet, and they're doing it. And this is all illegal. Under the EUA, there is no test to be performed, not collect a sample, to be performed at home. That's not going to happen. Now, when the pandemic is over and the FDA approves something, that will be a different story. We might be able to do that. But we're, again, talking about EUA, Emergency Utility Authorization. It has a different rules. So what can I do in my office? Easy and simple. You can get a cotton swab, put it, not a wooden shaft, no wood shaft, put it in the nose like half an inch, and put it in saline and send it to LabCorp. If you want to know, it takes 2-3 days. Now, since actually that has been available, the LabCorp will send you as many as you want as far as, swabbing kits. It's easy and simple with the normal saline. You can draw blood in your office and send it to a reference lab for the antibodies. They would do IgG and IgM or both. And you can give them a script. If you give them a script, they would draw them only for IgG. If you draw the blood in your office, they would do both IgM and IgG. Of course, hopefully we'll have more CLIA waived tests available for the doctors, so we'll do more and more and more testing, but we want to do it the right way. We don't want to do it in a way where actually that will have an illegal impact on the doctors. And this is going to come after you if you are performing a high complexity or moderate complexity test in your office and you say, I don't know. I spoke to Henry Schein. I spoke with him for an hour. He's trying to sell me a test and he said, this is CLIA waived. He told me that. Hanged up on him, called the state. Within 5 minutes, she said, give me his number. Give her his number. 2 hours, he called me back and he said, I'm sorry. It's did not get the EUA and this is high complexity. But hopefully very few will, in the future, will see things are better. Now, anytime you want to have a tent or a camel or whatever, check the weather before you put one. This is one of the things we were checking. We were testing people in the tent outside to protect our staff. And sure enough, when we had a storm, Thanks.
Okay, thank you so much, Dr. Bezarbashi, for a great talk. And thank you again to Dr. Alkana for her excellent talk that preceded his. So at this time, we're going to proceed with the question and answer portion of the webinar. As a reminder, all the attendees are muted. So if you would like to ask a question to either of our panelists, please submit it through either the question and answer function on Zoom or through the chat function, and I'll be happy to ask questions on your behalf. We did get a couple of questions already. So first question is a two-part question, and that is, which diagnostic test do you think would be used widely in the primary care setting? And what is the current cost / reimbursement for that method? Dr. Bezarbashi, I think that, with your private practice and primary care setting, maybe you can handle this question.
There is one, we already said that the serology test is not to make the diagnosis, neither to rule out the diagnosis. You do not use it to rule in or rule out. Only PCR or antigen. You can use both of them. Remember, when you do the antigen, which we only have one machine now, if the test comes back negative, you still have to do the PCR. So there's no other option, only PCR now. Remember, the PCR is not gold standard test. It's the best test available. Now, PCR is more expensive than antigens, much more expensive. We're talking about, something that will cost you for the PCR, will cost around $47 for each one. That's what I pay for it, actually. And the reimbursement Medicare is around $51. So there's not much of money made out of it. The antigen, you can actually make it for 10 cents, and probably they're going to sell it for you for $2, $3, and the insurance will pay $10. So it's much cheaper. But if the antigen is negative, you still have to go and do the PCR to rule out the disease, yes. But the PCR is still the best test available to now. You cannot rely on serology to make a diagnosis or to rule out. Those are just, as I said, to check how many people has gotten it, and to see if anyone has it, so we can use their blood to treat critically ill patients. So the reimbursement for the PCR are around $51, the antigens, I have no clue, and nobody has it.
Great, thank you, Dr. Bezarbashi. Another question that came in, what do you need to become a moderate complexity lab in a primary care office?
I'm so happy that you asked that question, because I did not want to go through in details. Not much at all, because you have to take training over the internet, and then you will be. Because as a doctor, you could be the director. You don't need a PhD. You need a PhD or pathologist, I guess, for the high complexity. The technicians could be anyone who has a high school. If you are high complexity, you need only medical technologists. So that's all you need to do the training. But after that, you're going to be inspected by CLIA, by state. And those people, you don't want to, remember the FDA makes the rules. And then the state and the CLIA enforce the rules. So the rules for the lab are a lot. So even if you do it, I advise to have someone, and there are people actually, or what they do for a living, to go and consult for those moderate complexity labs to make sure that you are in compliance. Because if the state comes and sees there's one mistake, they're going to shut it down. That's it. So you do the training online, and you can get the certificate, and you'll be able to do it.
Great, thank you. Another question.
Can I comment on that?
Oh, please, Dr. Alkana, please go ahead.
Yeah, moderate, because I have been involved in one of the scams that one of the doctors wanted to open his own lab, and he thought that it's so easy. And he spent so much money on the machines and everything. But eventually he realized that it was not really cost effective for him because of the heavily regulation and heavily involved by the state. If you don't have the volume, if you don't run by the guidelines and by what required from the state and from the federal, you can put yourself into a lot of troubles. And I know one time we have one of the lab, they have to shut it down for 6 months before they brought me back. So we can really had to put together all the pieces and to show them proof that everything is by the guidelines and change the policy. And then they really allow it back again. And they can be, any rumors can call the state, tell them that you're doing something wrong, they will come and they shut it down. So it's really be very careful with that.
Dr. Elkana, I was going to ask you a question that I know you alluded to in your talk, and previously you have explained to me in a way that is more eloquent than I've ever heard otherwise. But if you could just spend a minute commenting on the complicated nature of the pathogen and why maybe some antibodies don't necessarily lead to immunity. People talk about how, oh, you have antibodies, but you're not immune necessarily. And that seems sort of counterintuitive to most of us with a medical background, but you've explained this in a way that I think is eloquent.
Right. Any pathogens in general, they have probably certain or many proteins on their surface. When the pathogens goes inside the cells will recognize all these different antigens, and they can make different antibodies toward those antigens. But unless those antibodies that made against antigen will really kill the pathogen, if it comes back again, that means you can perform it, but they can really produce it, but it doesn't mean it's gonna kill the bacteria or the virus if it gets inside your body. And that's how they usually test during the vaccine research, is that they give you, they inject you with the weakened pathogens and see how much antibodies is produced, and they can expose you again to see if you really get sick from it or not. All depends, and they try different probably methodology by adjusting the antigen just to see which one will really work the best. And that's why they tell you, okay, you have the antibody. Am I immune? I don't know. You could be reinfected, you could not be. The only time is because we are still in the beginning of this pandemic. We don't know how this virus is behaving in general. As we know from the history, some of the viruses like chickenpox or smallpox, they can give you for life immunity by vaccination. But certain certain viruses like AIDS virus, they could not produce antibody because these keep mutating all the time. So they cannot really produce constant type of antigen that will give you one antibody. They keep changing, so that means the immunity will not be produced. And certain like the virus, the cold virus or the flu virus, it's every year because these keep mutating. They have to make what is the most common antigen that could be really inhibit that virus or at least weaken it. So that's why I tell you people that get infected, but it's not as bad as when they don't have the vaccine. It's the same thing, but because of the mutation, they have to do it every year. So some of the viruses can give you full-time or lifelong immunity, and some of the viruses give you very short immunity. With COVID-19, we don't know yet. It's all up in the air and all is in the research. And we're hoping that the vaccine that will come give you at least 1 year immunity. At least people can really feel more comfortable.
Great, thank you. Another question from the audience. Please clarify what is the difference between PCR testing that takes 2 days and the Abbott rapid testing that takes a couple of hours?
Now, the PCR, there are two types. Well, there's one type for the PCR. When the first PCR has got the EUA, if you remember, actually, that was Roche. They got their analyzer to do the PCR. This is to do mass testing. And at that time, there was nobody else is doing it. Now, you're talking about a huge analyzer. At the beginning, it was taking 7 days, not even 2 days. Now it's taking 2 days when you send it. So it's a big analyzer for big, high complexity labs doing mass testing. It should not take two days, actually. It takes 2 days because they are overwhelmed. You run it once a day. It should be done by the end of the day. When you compare it to Abbott Id, Abbott Id is a point of care. It's like the machine I have the BioFire. Like now, actually, every patient who has to go for any procedure, elective, has to have a PCR swab 96 hours or 94 hours before the procedure. So sometimes, I mean, before of the time factor, so some doctor will send me the patient, and I do it in the morning, and we get it in an hour. But the machine can do 2 or 3 or 4 or 5. You can put up to 10. This is not mass testing. This is not an analyzer. It's not a big analyzer. This is a small machine to do single test. But both of them actually, even the big one does not take a whole day, but it takes days because you send it into a different lab. Every time you send it to a different lab, of course, it's going to take time for transportation, and that depends how busy they are. And then to perform the test, when you're doing something in your office, you get the results within half an hour, 45 minutes.
Another question that I was hoping someone would ask, and it is, as employers require 2 negative tests after an infection, we are still seeing that 1 month later, one test is positive and another is negative. Why is this happening?
Now, this is not the requirement of the Department of Health. It's not. It has been required for a healthcare provider to have 2 negative swabs. Now, again, this is not from the CDC or the FDA. If the PCR, as good as it is, or what it tells you that the RNA of the virus is there. Like you open the room, and you saw a body. If this alive or dead, you don't know. But you know that it's actually the body of whoever. So this is probably most likely dead virus. And it might stay for 2-3 months. You should not actually rely on it. You don't even need to re-swab. They were doing that because only for healthcare provider, because they want to make sure, be 100% sure that they're not gonna transmit it to other people. We saw that actually in the urine and the stool. They were saying a lot of positive PCR, and they went and they tried to culture it, and they could not. That tells you this is dead virus, and there's no transmission. Initially, we said there's transmission through the urine and the stool because there was PCR, but they don't do the culture, of course, for the viruses, only on research. I wish they could. So if your patient has positive, but he has no symptoms, I think you should feel 100% confident that he's fine. And that's what triggered, if you remember when the whole thing started, saying people are re-exposed and they are getting it again. That was happening. Those people were still positive and they thought they were re-exposed. It was not re-exposure. It was a persistent shedding of dead virus. What can add to that, again, we're talking about perfect scenario. If you could do the blood and you see that was negative, and then the patient have IgG. We're still talking about immune competent patient. Immune compromised patient might be actually a little bit different actually in here. They might not be able to fight the infection. They might not be able to develop the immunity against it. But talk in general, immune competent patient, if you see that even if they are still positive, this is shedding dead virus, providing no symptoms, of course. Patient is feeling great. I would not even worry about it. And I have actually several patients like that.
Just to mention something, that this is, since it's a pandemic and it's a new virus, we still, a lot of things, we are learning it as it's happening. It's in real time. So what we know now might be different a little bit later. All the unanswered question could be answered later, and all what we think now could be different. So it's the best of our ability to compare this with other viruses similar to it, and then we make assumptions and expect with certain testing, but after that, once more research is done, usually we'll be able to really decide how the disease is behaving and answer all these questions that people, that they are really people concerned about. But again, information is very tough now to have it all. The questions, there's no answer for each one of them.
But if you still have a patient who's feeling good and still have positive,
right,
just feel comfortable, because we don't know everything, but what we know enough that this is the virus, most likely 90% or more.
Great. Just one last question, I think, before we close, and hopefully and I don't know if anyone has an answer to this one, but the question is when do you think we will have a rapid finger test for COVID-19?
We do. ChemBio. ChemBio, I said there are 5 of them that are rapid tests. The Selects, which is impossible to get. The second one was ChemBio, and I did order it, but the problem is, again, they're all moderate complexity. All of them, none of them is point of care, none of them is a clear wave. The ChemBio, you have to buy at least 2,500 tests, and it's almost 65,000. And you could do the finger brick.
I think it's more of like a point of care finger stick, like we can do for blood glucose sort of thing. If you think that there's going to be something like that.
The answer is very clear. As long as we have an EUA, as long as we are still in the pandemic situation, the FDA coming from them has no intention to do it. Now, if let's say the pandemic is over, let's say in August, and all those people, they go through the normal process of being approved by FDA, we might, or most likely we will. So that's, again, everything we're doing now, it's an emergency situation rules, and they do not want to approve anything for those serology rapid tests to be clear waived.
Okay. So it is just about 9 p.m. on the dot. I want to, respect everybody's time. Thank you so much to our panelists, both Dr. Bezirbashi and Dr. Al-Khanna. You guys spent a lot of time and hard work to prepare for this webinar, and we really appreciate it. And thank you to everyone who attended. We hope this was informative and helpful. And the webinar tonight was recorded and will be available for future viewing if you or your colleagues are interested. Thank you, everybody, so much, and hope everyone has a good night.